If the patient gets relief from that, we've properly identified a pain generator. So I think when pain management is done and the sequencing is done correctly, and we're really, the goal is precision diagnosis, then I think it's an amazing tool. I just don't see it utilized that way very often. Um, and on the flip side of that, I don't see enough referral from the pain management side of the house to tell the patient, hey, great, we're going to do some procedures. In the meantime, we need to be making sure we're addressing the main structural mechanical dysfunction.
Welcome to Beyond the Pain, the podcast that explores what it really takes to break free from chronic pain and reclaim your life. I'm your host, Lee Brandon, and someone who's spent over 2 decades helping people get to the root cause of pain that no one else could explain. Whether you're dealing with long-term back issues, joint pain, nerve discomfort, or mysterious symptoms that just won't go away, this show is here to help you go deeper. Because beyond the pain, there's clarity, strength, and power waiting for you. Each week, we'll uncover the physical, emotional, biochemical, and energetic causes of pain and how to transform them. Let's dive deep into this week's episode. Most people who live with chronic pain are told one of 3 things. It's wear and tear, it's degeneration, or it's just something you're going to have to manage. But what if the real driver of your pain isn't actually what's showing up on a scan? What if it's years of cumulative microtrauma, restricted soft tissue, or even a nerve that's quietly trapped and irritated every time you move? In this episode, we explore one of the most overlooked contributors to chronic pain, soft tissue dysfunction, and nerve entrapment, and why these issues often get missed in conventional assessments. We talk about active release techniques, how repetitive stress builds up over time, why posture still matters, and why pain is far more complex and far more subjective than most people realize. If you've ever been told there's nothing wrong, but you still hurt, or you've been managing pain without truly resolving it, this conversation may change how you think about what's really going on in your body. So let's dive in. Dr. Matt, welcome to Beyond the Pain. It's great to have you on the show.
Thanks so much for having me. Honored to be here.
Yeah, it's great to have you on. And to kick things off, could you share with the audience kind of a bit about your story, your background, how you got into health and the kind of things that you're doing today?
Sure. Yeah. Well, the high level, quick Cliff Notes version is I've been a sports chiropractor for going on 25 years. Grew up as an athlete playing sports, everything from swimming to football, baseball. Got exposed to athletic training in high school, fell in love with it, and that was kind of my kickoff into that. And went to undergrad, went right from there to chiropractic medical school, and have been primarily sports med focused for the bulk of that career. That's kind of it in a nutshell.
Great. Yeah, just for the audience in Europe, because we don't have athletic trainers, probably the closest we have is physiotherapy. It's probably the
Yeah.
closest to that. It's a slightly different, I know.
Yeah. In the States, there's a lot of overlap in healthcare in general. So athletic
Oh,
training, typically those are going to be, people who are going to be on site at high schools are going to cover practices, are going to cover games, or kind of your first responder triage for sports
mm,
injuries, and they'll coordinate
yeah.
care between orthopedics and concussion clinics and sports chiropractors. So when we look at, sports at a high level, they're going to have a well-rounded team. They're going to have athletic trainers, strength and conditioning coaches, multiple athletic trainers, usually under the head athletic trainer, and everybody in between, from equipment managers, every medical specialty you can think of. And there are quite a few physical therapists that they start out in athletic training track, or a lot of them will actually go to
Mm,
school where they'll double major. They'll get an athletic training uh, graduate or certification, graduate with a degree in athletic training, and then they'll go on and graduate with a doctor's in physical therapy. That's fairly common. Um, so, and yeah, it's they're usually on field, on site to triage the injuries as they occur in real time.
Yeah. Yeah, I know, Dr. Mike Leahy. I don't know if you're familiar with him.
So Mike Leahy is the developer of Active Release, which is the certification we're doing in house today.
Oh, really?
Yeah, yeah,
Wow.
yeah. So I've known Dr. Leahy since probably, well, I knew of him back when I was in school,
Right.
'97. I'm a little fuzzy on the date. I think he kind of developed ART in the mid '90s. '96, '97 was the first time I heard of it
Mm,
in the Ironman triathlon world. And of course, Mike's a Air Force Academy graduate, and um, the active release training has really evolved over the last 25 years.
mm.
And so that's interesting. Yeah, small world.
Yeah, small world. What made me think of it was the fact that, I've seen videos or pictures of him running onto the field for the, which team
Denver
is it?
Broncos.
Denver Broncos, yeah.
Yeah,
Yeah, and I'm fortunate, I've been taught by Dr. Leahy myself, like, and it's amazing when you got someone who's got that level of knowledge and experience, when,
yeah,
you've been treating clients even, using ART for a number of years, and then he's teaching the class, or at least part of the class, and you could have your hands on someone and he can just move like the angle of your thumb just like a couple of degrees, and you go,
that's right.
and how does that feel now? Oh my god, that's like that's
Yeah,
so um like, just makes such a big difference, but such a small little change that you've made. Yeah, his
yeah.
level of skill is pretty amazing, and ART, I absolutely love it. I've been using it for like 12, 13 years now.
No, awesome. Yeah, that's
Yeah.
great. Yeah, I mean, I always tell people when you're doing certifications and you think you've got good touch and pressure and everything, and then Dr. Leahy comes over and he just makes those little micro adjustments, millimeters of direction, vector, ounces in terms of, less compression, more tension. Um, I mean, thank God for active release because it's a game changer and our ability
Mm,
to, handle soft tissue and fascia injuries, more importantly, nerve entrapment. So we were just talking, we've got a group of, I wouldn't say younger docs, but docs that are just coming on to the ART arena. They're getting their first, second certification. So a lot of the thought process and a lot of the things that we see clinically, we're trying to bring them up to speed on how to make sense of things. And we were just talking about the nerve component, and somebody brought up, you see a lot of times when their nerve conduction studies are normal, so to speak, and so they go to these
mm,
other various doctors, orthopedics, neurologists, and they tell them we can't find anything wrong. And
mm,
so what I said to the group was to try to stress to them is the importance of these small sensory neuropathies that are responsible for probably 80% of the symptoms that we see day to day in a musculoskeletal clinic. Um, they're not picked up by standard nerve conduction studies. There's nerve irritation, but it's not so far down the road where, it's going to be picked up on a test. And so subsequently, most of these patients, unless they see an ART provider, the doctors that they see are kind of scratching their head to try to figure out what's going on, if they even entertain it as a legitimate symptom to begin with. I think a lot of patients,
mm.
are kind of pawned off as the provider can't explain what's going on. So they do some imaging, it comes back negative or normal, and they get kind of brushed off. And
Mm.
unfortunately, a lot of those patients can go down that cycle for years without a whole lot of solution until they finally stumble upon, hopefully, an ART provider who can shed some light on it.
Yeah, I mean, what I've experienced is people often feel like they've been gaslit by a
Yes.
practitioner. It's almost like, we don't believe you're in pain, right?
Yeah. Right. As if
Yeah,
they
why
got
would
nothing better to do than to come in and
yeah,
waste their time to,
yeah. It's
yeah,
crazy, isn't it?
it's
So
unfortunate.
so you got into your line of work, I think like myself, very sporty as a young person, became involved in chiropractic, working with lots of sports people. You've obviously been doing it a long time. What what's motivated you to keep doing what you're doing?
I mean, it's going to sound textbook, but at the end of the day, it's really just about trying to, push your skill set to the next level because no matter how long you've been in practice, there's always going to be that patient that comes in that throws you for a loop and you're struggling to figure it out. You've tried what's worked in the past and, we get complex cases. And I think, not being complacent and being okay with being able to help 80% of the people who come in, we're all, at least for myself, I'm trying to, get towards that 100% mark. We're pretty fortunate with the tools that we have to do some really good work. And it's rare that we aren't able to make a positive impact. More and more as I get further on in clinic, that positive impact comes in a collaborative sense, especially now with regenerative medicine. We're real big on that because there's only so much we can do with our hands,
Mm,
and the field of regenerative medicine really helps us to push the gas pedal down on the body's ability to heal and recover. So I think that's part of it is really just trying to stay at the top of your game because at the end of the day, I mean, that's a human being on the other side of the interaction. And a lot of times the patients that we see, they've been everywhere else.
mm,
They've exhausted the medical route. They haven't gotten a whole lot of answers, certainly not a lot of lasting solutions. And that really, that falls on us a lot to be the person to kind of connect the dots,
mm,
figure out the things that they missed. And I would put number one in that is the mechanical dysfunction that people have, meaning structural misalignment, soft tissue injury, fascial restriction. And at the top of that list is nerve involvement. So peripheral nerves being entrapped and embedded in the fascia. Again, thank God for the ART training because the nerve
mm,
courses that they offer, I mean, it just opens up a tool set for us to be able to take care of these people that without that, even if you had an inkling that it was a nerve issue, you're not equipped with the tools to fix it.
mm.
Yeah.
Yeah, one of the again, it's a story my audience have heard me say a million times, but I'll share it with you and obviously anyone that's new to the podcast. But I remember some years ago, someone came to me with carpal tunnel syndrome, and she'd said, I've been seeing a physio for 12 months, 3 sessions a week,
Wow.
nothing's changed."
Yeah.
And I said, "Well, look, let me see if I can release some nerves down that tracks." And I did a 10-minute treatment and she got off the table and she looked at me like, "What have you just done to me?" And I'm like,
Yeah.
"Why? What?" She went, "The pain's gone." Right. And then she came back for another 2 sessions, even though she still wasn't in pain because she couldn't believe that the pain had gone,
Yeah.
you know?
Yeah. It's
So
really
it's
impressive.
a powerful tool to have in your toolbox for sure.
Yeah, and we were talking about this morning is, some of these younger docs that are starting to develop that clinical thought process of, going through patient presents with certain set of symptoms. How do you work that up? A lot of times they come in and they tell you what the problem is. If you have this set of tools that allows you to go through and do the diagnostics, and then we
Mm,
we literally put our hands on the area and we start to work up and we can do different movements to tension nerves and find out where they're restricted. And then we just kind of start to work from, certain points and, you know, being able to do that on a patient who's been treated or have seen multiple providers, that's a huge aha moment. And when they get up off of the treatment table and they notice real-time results, I mean, you just can't fake that, you know?
mm,
So it's amazing. And it's great because it creates buy-in with the patient. So now they realize for the first time a lot of times that, hey, maybe I'm not crazy and this is an actual real thing. Um, I find it sometimes difficult to get the patients to understand really what's happening when we're talking about nerve entrapment. So I like to use the Velcro and the spaghetti noodle model.
mm,
They kinda get that when you talk about,
mm,
imagine this nerve, they're different sizes, but let's take a spaghetti noodle, and, you explain that to them, and you can kinda see it in their eyes when they kinda get, like, "Oh, the nerves are supposed to slide, and at this particular spot, it's Velcro to Velcro, the nerve's being entrapped." And then once you treat it, the cool thing about ART is diagnose, treat, reassess all in the same treatment. We don't have to
mm,
wait for an MRI to come back. Um, I mean, we will obviously do imaging when we need to, but that kind of hands-on diagnostic, it's amazing to be able to see that in real time, and it's great for patient education because they get that real-time feedback.
Yeah, it's such a great tool. I mean, I've had a number of occasions where, someone's come to me for ART, and again, it's another story I've mentioned so many times, but there's one story of a guy, he just started training to do marathon running. He was 42, never done any exercise in his adult life before, but
Yeah,
he hired a running coach who was based in the US, and he said, "You've got to get yourself an ART therapist to work with you."
smart.
So he
Yeah,
hired me, and he would come in every week, and I'd work on him, and it was his calves were, they were always really, really locked up.
yeah,
So I'd release his calves, and I would say to him every week, "You do realize that if you did other things like exercise, change your nutrition, maybe
yeah,
some other lifestyle things like getting to bed earlier, you'd actually be in better condition every time you come back to me every week, and you're going to reduce your risk of injury." And I was selling him on the bigger picture,
yeah.
and he's he's kind of thinking was, well, that's expensive to do everything, right? And then, ironically, I think it was 6 weeks before the marathon, he got a real serious back injury.
Mm,
So he came in to see me, and I said, "You remember what I said right at the beginning? Well, really, you should get a proper exercise program, nutrition, lifestyle." And he was like, "Oh, okay, yeah, okay, right, let's do it." But the reason I bring that up is because you can work with someone with ART, and because they see and feel the benefit, they now trust you on the other things that you have to offer as well.
that's right.
You know,
Yeah.
I mean, I'm working with a lady at the moment, plantar fasciitis, and her pain was an 8 out of 10 when she
Mhm.
first came to see me. At the end of the first session, it was 3.5. At the end
Wow.
of the second session, it was 1.5, and then I think it was 0.5 after 3 treatments.
Yeah.
Now it's been a few weeks, and it's increased again. And I can say, so look, you can keep coming back for treatment if you want. I said, but there are other things you can do as well,
That's
right,
right.
to help prevent what's caused it in the first place.
Yeah.
And she's like, "Yeah, I'm going to come back to you on that. I'm off traveling, but yeah, we'll look into that at a later date." But just coming back to, we mentioned earlier about how sometimes people in pain, they can kind of be a bit gaslit, and if the practitioner doesn't understand what's going on, or they can't find something on a scan or blood test or whatever it might
Right.
be, they kind of think that the person's making it up. It's all in their own head. But what I think an important question is, and I'd like to get your view on this, is what is pain? What do you think pain is? I'm going to pause briefly for a final reminder. Beyond the Pain, discover and remove the foods fueling your pain in just 14 days begins next Monday. That's Monday, the 2nd of March. Enrollment will close shortly, so the group can move through the process together. If you're interested in learning more about how food and inflammation may be influencing physical discomfort, or simply want a clearer framework for understanding your body, the program details are available in the show notes. All right, let's continue.
Well, I always default to Dr. Carrick, and he said this, and I remember hearing him say this back in like 2000 when I was coming out of school, that pain is a primary perceptual experience, meaning you and I are the only people who can experience the pain in our bodies. The
Mm,
doctor can't feel it, they can't sense it. Certainly, we can describe different types of pain, sharp, dull, achy, and those can correspond to different anatomical structures in the body. Uh, People have different pain thresholds. You hear that all the time. People come in and they're like, "Oh, I got a high pain threshold." I've almost never met a patient who has admitted to me they have a low pain threshold. They are far and few between. Um, People tend to gravitate and think that they can tolerate a lot of pain. And I think one of the things that patients fail to appreciate is that your nervous system, it's a dynamic thing. We can wind up the nervous system, we can shut it down. And when you've been dealing with pain in an area for a long time, that those tissues get sensitive, hypersensitive. So now normal, non-painful stimuli is creating pain and irritation. So that's a difficult thing because if a patient's having a cardiac event, we can run an EKG, We can run calcium artery scores. There's a lot of things we can do to be able to objectify those pathologies. But when we're talking about pain, outside of doing a functional MR where you can see different areas of the brain light up, and a lot of what we know in pain science today comes from exactly that. Um, it's difficult to describe to a patient that the pain pathways don't just go to the sensory cortex in the brain. They also have feed offs that go to the limbic system, and then you get into explaining how that affects mood and affect and all these different things. So I think that was one of the greatest things that I heard in terms of putting it into perspective because we've all experienced pain personally. So we feel like we can tell what another person's pain is. And certainly we can to a certain extent if we've had a similar injury, right? You mentioned the plantar fascia case. I would argue 80 to 90% of the pain in a plantar fascia case, yes, it's due to soft tissue adhesion, but the primary pain generator is the nerve, either the medial calcaneal nerve or the lateral plantar nerve, right in there at the bottom of the foot. And when you start to show these to people, especially on the Visibody app, I'm sure you have the Visible Body app. That's
Mm,
just an amazing show and tell tool. It's 3D. We can highlight structures. We can take structures away so we can show patients where the nerve courses. And then they kind of have this visual of what's going on in their body. Um, so if you've had a similar injury, we can kind of reasonably well empathize with the patient on what that feels like. But I always joke with patients, if you're a healthy cardiologist and you've never had a cardiac episode and you've never had chest pain, how do you know what that feels like?
mm,
Coming from an athletic background, I've probably had over half of the injuries I've treated. So that's kind of a bonus, it's kind of school of hard knocks, but it's a really good experience to be able to draw from. Um, pain is a very difficult thing, and certainly we're far further down the road today in terms of how we manage it. But it is a difficult thing. I mean, there is a reason why there's an entire field of medicine dedicated to it. I don't think we've done a great job, at least here in the States. I think we're too quick to send patients down the rabbit hole of pain management.
mm,
Um, and I don't see enough, in my opinion, collaborative treatment between the pain management docs referring back to the other providers in the field that can help address really a lot of the mechanical causes for the chronic pain.
mm,
We can talk about complex spinal conditions. That's kind of its own category. But if we take that out of the equation and we're talking about people that just have peripheral nerve entrapments elsewhere in the body, um, and even things like complex regional pain syndrome and things like that. I think that a lot of times we are too quick to just jump right into the pain management pathway. And with the mindset of thinking that that's a standalone, that's all we need to do. Much like the people
mm,
who come in and they're getting active release, they're getting a little bit of results or they're getting a lot of results. And it's a double-edged sword because a lot of times it's hard to get them to realize, hey, we should be prioritizing sleep, hydration, making sure we're controlling inflammation, uh, working on daily mobility work, whether it's yoga, foam rolling, stability, strength and conditioning, core training. It's difficult to get, especially runners, because they just want to go out and ground and pound. That's been my experience. It's very hard to get them to do the
mm,
preemptive stuff. Um, and you kind of tell them it's like, hey, if you take time to sharpen the saw, you get twice as much work done in half the time. A dull saw, a dull axe, you work twice as hard, you get half as much done. It's difficult to take that runner and get them to give you 20% of their training week devoted to some kettlebell training and different things like
mm,
that. So I think what happens ultimately is they get they move from injury to injury, and finally there's an injury that just strikes a chord with them where they're like, all right, enough is enough. And what do I need to do to prevent this from coming back again? Especially if it's a runner that they miss an A race. They miss a marathon or a half marathon that they're training for. A lot of the runners that I treat, they may have maybe one or two or three big A list events that they're going to do for the year and then a bunch of training events. And if they're not healthy to do those, that really causes them a moment of pause to
mm.
really kind of reevaluate, are they prioritizing their training the best way? Yeah.
Yeah, interesting. There's so much I want to feed back on. Hopefully, I'm going to remember everything because there were so many things that you were triggering in my own mind. Um, it's interesting, like yourself. I've been involved in sport pretty much all my life competitively since I was 6. So that's over 50 years.
What's your big sport?
Um, Tennis.
Oh, yeah. That's tough on the
Uh,
body. Are you
oh
pickleballer
yeah,
today?
no, 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 proper tennis, proper tennis.
Got it. That's great.
Um, when you said about runners don't like to do anything other than run. First of all, yeah, that's my experience of working with runners, and I've worked with lots of runners.
Yeah.
The second thing I thought was it's the same thing with tennis players. All they want to
Yeah.
do is hit tennis balls, right?
Yeah. Yeah.
Um, but my experience playing sport has been, I've ruptured my L45 and L5S1 discs. I've had supraspinatus tendinosis twice,
Yeah.
and I've had a grade 1 ACL tear.
Mm.
Which injuries do I see most commonly? Lower back, shoulder, and knee.
Yeah.
And what is great, and this comes back to my original question, what is pain? I look back at those experiences as gifts.
Yeah.
The pain that I went through was a gift because I can now empathize when people come in with those same conditions,
Yeah.
and especially the lower back one because it's so life changing. I mean, I'm fine now, right? 22 months of rehab, I was fine.
Yeah.
Um, but you know, you can learn so much from a textbook, right? You can learn so much from a certification program. But when you wake up and you can't flex your spine
Yeah.
and you can't feel your left leg and you can't walk on your left leg and you don't even know how you're going to put your underwear on.
Yeah.
That's when you start learning, right?
Yeah.
Um, so going back to my original question, I see pain as a way that your subconscious mind makes your conscious mind aware of something that you're not aware of, right? So
Yeah.
if you step on something sharp, your nervous system will make your conscious mind aware because obviously you're not going to step on something sharp consciously, right? You're going to do it unconsciously.
Right.
So just as something starts to potentially break through your skin, your brain's going to say, "Oh, there's something sharp. I need to contract some muscles to lift my foot off that sharp object," right?
That's right.
But I like another way to look at it is it's the way that our our body perceives danger from its environment. And I liken the nervous system, the pain system, if you like, a bit like a fire alarm in your house,
Yeah.
right? If you're in bed at night, fast asleep, and there's a fire in your home, you want your fire alarm to go off to make you aware of something you're not aware of,
That's right.
right? It's a danger signal. The only issue can be is that yeah, the fire department can turn up, they can put the fire out, but if the alarm doesn't turn off, right? The fire's gone, but the alarm can still keep going, right? So
Yeah.
people can heal tissues, but if they've got other things going on, which is why, we focus so much on the biomechanics, the nutrition, the hydration, the sleep, the recovery,
Yeah.
the emotional stress, right? Because if that nervous system is still, wired, that pain signal might not be turned off. So that can be a big thing. And I think that's important to educate people coming in pain that all it is a warning signal, right? Yes, if you've just broken your leg, you want to know, because you don't want to put more
Right.
pressure on it and make the break worse, right? But once that bone is healed, shouldn't really still have pain there, right?
Yeah. I mean, I think it's, you brought up a lot of good points, and I think it's a good opportunity to unpack. Like, um, I always tell patients pain is a lagging indicator. Yes, it's the fire alarm system, but a lot of times it sounds too late. Something catastrophic and it goes off right away. But a lot of the things that we see, they kind of they start off as kind of nagging injuries, and patients will say, "Oh, it's not that bad." And then eventually, as the cascade of the tissue dysfunction, joint misalignment, muscles being repetitive motion injury, tissues getting tighter, we're not getting good blood flow to the area, inflammation, all these different things can cause a seemingly harmless, soft tissue and joint dysfunction that's not that big a deal. But over time, if we continue to do the sport that we're doing, fill in the blank, whatever it is, without proper intervention and treatment, then those tissues continue to incur more and more damage. Now, that can be very,
Mm,
very incremental. So it can take a long time for these things to happen, to where the patient comes in and they'll tell you, I don't know what happened. I didn't do anything different last week. I did my normal routine. And they fail to respect the process because they're looking for a catastrophic event.
mm,
Um, you mentioned that, yeah, we could send the fire department in, and we certainly can do that. And you're right, the nervous system a lot of times now has rewired around. And so there's a couple different things. If it's a nerve issue and the nerve gets irritated, say a peripheral nerve, people will think carpal tunnel, but there's all kinds of examples. The plantar fascia case, most of those have a nerve component to it, a nerve entrapment. So we can do things to free up that nerve. There's going to be some lag time for that nerve to regenerate. So we've done the work. Fire departments come in, we put the fire out. Now it's time for salvage and overhaul. I mean, that could take 3 to 6 weeks or longer. And that's where I think a lot of times things like regenerative medicine can come in to speed that process. If people
mm,
are impatient and they don't want to wait it out, um, something simple like a uncomplicated orthopedic fracture, you put it in a cast within 72 hours, most of that pain is subsided and the body goes right into repair and recovery. But I think what we're talking about are injuries that happen. Um, they're less traumatic or they're not traumatic at all. They're due to repetitive motion and they happen over
mm,
time. Um, so I think it's something that most patients fail to recognize. They think when they first recognize the pain that the injury or whatever just happened a day ago. And you'll see this a lot with I see it with patients who were actively rehabbing them. So they're coming off an injury. It could be a lower back case, whether they have disc involvement or it's facet mediated, meaning it's just the joints in the back.
mm,
Um, and we're getting them back into strength training and kind of return to play, whatever that sport is. I always use a guideline of, hey, let's say we're starting to get you back to running, or we're getting back into doing some squatting in the gym. It's really not critical. I mean, if you have pain during the activity, we should be cease and desist until we figure out what's going on. But if you're able to do the activity and you feel pretty good, and even the next day you wake up and you feel pretty good, but a day later, 48, 72 hours, you're paying for it, that's a sign to us that the tissues and the joints are not ready for that activity yet. So again, there's your lagging indicator. They think I squatted 3 days ago and I was fine. Or they have they go in and they do a workout and then 3 days later they find that they can't bend over. Excruciating pain, muscle spasm. That's probably a disc injury that was in process for months, if not years, and
mm.
it finally crossed a tipping point, and that's one of the most difficult things I think to get patients to realize that that's been happening over time. You know,
Yeah.
I think a lot of people will go to the dentist and they'll, let's say they have a cavity. I think most people kind of take it for granted that that cavity didn't just happen from the Snickers bar you ate yesterday. It's been there for a while.
Mm,
But when we're talking bone, muscle, joint, especially fascia and soft tissue stuff, I find that a lot of patients, there's a disconnect there and they don't realize that, oh, it didn't just happen yesterday.
mm,
So it is difficult, but I think there's something to be said for getting patients to realize the role of inflammation in winding up the nervous system in terms of it's putting their nervous system at a uh, code orange. We're on DEFCON 5 alert, and the nervous system is just hypersensitive versus somebody in a normal, healthy state where their nervous system is more balanced, their nervous tissues are able to slide freely. I think a lot of people today are just in a hypersensitive state to begin with, and then we throw injury on top of that, and they both feed
Mm,
off each other.
mm. Living with persistent pain can feel isolating, like you're meant to figure it out all alone, but you don't have to. Sometimes you just need someone who understands biomechanics, nutrition, gut health, emotional stress, and the nervous system all at once to help you make sense of your symptoms. If you'd like that level of support, you can book a discovery call at bodycheck.co.uk/consultation. Now, back to the episode. You mentioned kind of conventional treatment when it comes to pain. What's your what's your view on the kind of current medical system when it comes to helping people with whether it be a sports injury or even more of a chronic type pain condition?
I
Without
think the
without
system's
with sorry, without swearing.
yeah, yeah. I think the system's broken.
Yeah.
I think a lot of times the sequencing is wrong. So I'm not anti pain management whatsoever. I am anti how we're doing it, at least in the United States. When I
Mm,
see a primary care doc send a patient who has an MRI and they have some back pain immediately to pain management and they don't send them to chiropractic and physical therapy, at least at the same time, that's a
mm,
problem with sequencing. And I think a lot of it
yeah.
comes down to a lack of training, you know. Um, I mean, I did my residency at Texas Back Institute. The next pod over from me was a pain management doc. So my first experience in practice was very integrated and very collaborative. We were doing uh, joint injections, facet blocks, nerve blocks, epidurals. I mean, we were doing them on the regular. And, we saw complex spinal cases there, but certainly you had people coming in there with what I would just consider garden variety neck and lower back pain. Just because you have a disc bulge in your neck or back, that doesn't necessarily mean that's a special case.
Mm,
Statistically speaking, 30% of people have disc bulges in their neck or back. If we MRI 10 patients, we're probably going to find 30% of them have some kind of disc degeneration or bulging. And a lot of those patients may not even have symptoms. So,
yeah, there was a study done by Booz et al. That showed
yeah,
76% of people with bulging discs were asymptomatic.
yeah, yeah, it's true. And,
So,
and a lot of the discs that we see, we'll test them in office and sometimes they are disky, meaning they have a flexion intolerant spine and the disc is inflamed and herniated to the point where when they move a certain way or they axially load, like
mm,
sitting or squatting, it regenerates pain. But more often than not, their main pain generators are different areas. They're the facet joints in the spine or the pelvis. They have nerve entrapments and different things like that. So this is where pain management gets very myopic, in my opinion.
mm,
They're
mm,
looking at that disc saying, "Ooh, let's do an epidural because hey, why don't we do that?" Well, if you take lumbar epidurals, they're about 50% effective, and that's for patients that have a disc confirmed on MRI and actually have lumbar radiculopathy, which means that disc is causing inflammation and irritation to that lumbar nerve root, pain shooting down the leg below the knee. What about the patients who go in and have epidurals and they don't get relief? Well, the reason is they didn't properly identify the pain generator.
mm,
And when we look at, the different anatomical structures that can cause pain, it's joint, muscle, fascia, ligament, tendon, nerve. And in the spine, it's a little complex because you have two bones with a disc in between. And that disc, when it ruptures or herniates or bulges, causes an irritation to the nerves that innervate the backside of that disc, called the recurrent meningeal nerve. So once that gets irritated, that can be a source of discogenic pain. It's usually very localized. Those patients tend to do well with pain management intervention in the short term. So we'll use that window to get them some pharmacologic relief so that allows us to be a little more aggressive on the treatment side. Because if somebody's in that amount of pain, we're limited as manual practitioners as to what we can physically do to them. They're
mm.
limited on what kind of exercises that they can do. So I think we're too quick to just do a bunch of procedures. I can't tell you how many patients I've had who have come in. they get in the rabbit hole of pain management, and it's just injection procedure after injection procedure. Now, when it is utilized properly, um, let's say you have a patient and you suspect they have a little bit of disc involvement, and you get an MRI and they have a disc problem, whether it's a bulge or whatever, but you're not quite sure, is that the primary pain generator? So a lot of times we'll refer them out to do a facet block. Now, what they'll do is they'll block the joint at the level and the joint above and below. And the reason being is in the spine, let's say this is L4, that joint's getting innervation from the nerve above and below. So what they'll do is they'll do a
Mm,
facet block. Now, that's a diagnostic. If the patient gets relief from that, we've properly identified a pain generator. So I think when pain management is done and the sequencing is done correctly, and we're really, the goal is precision diagnosis, then I think it's an amazing tool. I just don't see it utilized that way very often. Um,
mm,
and on the flip side of that, I don't see enough referral from the pain management side of the house to tell the patient, hey, great, we're going to do some procedures. In the meantime, we need to be making sure we're addressing the main structural mechanical dysfunction. And you can't do that through an injection.
mm.
That requires the manipulative uh, therapies to the joints, to the soft tissues, active release, rehabilitation, mobility, stability, motor control, teaching patients how to move properly again, increasing core strength, all those different things. That's really what a collaborative approach looks like. And I think that we've just gotten too myopic, and pain management tends to live in their 3-foot world. So
Mm.
same goes with orthopedic and neurosurgery. And it needs to be a little bit more broad based, and I think ultimately doctors need to do a better job of communicating with each other.
Yeah, completely agree. Completely agree. I think there's a place for everything, but it needs to be done in the right way, and as you say, at the right time.
Yeah,
You know, I
sequencing matters, it's doing the right things better, and that really comes down to the sequencing, because you can be doing the right things out of order, you're not going to get the outcomes that you're after,
mm, yeah,
and
I remember when I went to see my GP when I had my back issue, and like you was alluding to, I just woke up one morning and I just couldn't get out of bed. Right,
yep,
I wasn't doing anything athletic in bed that night.
yeah,
um, but you know, because of my training, I kind of thought, well, it feels like my L4 and L5 dermatomes. So that made me think,
yeah,
oh, it's probably my L45, L5S1 discs. But I just wanted to get an MRI just to make sure, it
yep,
was what I thought it was. And when I went to see him, very quickly he said, "Oh yeah, I'll refer you for an MRI. That's not a problem. Um, here's a prescription for painkillers and anti-inflammatories." And I just said, "Oh, look, no, don't worry, I'm not going to have them."
yeah,
He's
that's
like,
right,
"What do you mean?"
yeah,
And I said, "Well, look, I know if I go into flexion, it causes me to, I get a lot more pain shooting down the leg, right?" I said,
yeah,
if I'm putting more compression or rotation or whatever stress through that disc, and it's potentially creating more damage to the disc, I want to know about it.
that's right,
And he looked at me like I was a madman. Um,
yeah,
but looking back, it was I mean, I could manage the pain. I guess because I was looking after my hydration, my nutrition, my sleep, and everything else. Perhaps
yeah.
my level of pain was much lower than someone else that would have the same condition because there's less stress on the nervous system, right?
That
So,
is true. That is true 100%. And there's also, it goes back to, again, that pain's a primary perceptual experience. So I would agree with you 100% because of, number one, coming from an athletic background, pain's part of the game. You're always hurting somewhere. It doesn't mean there's real tissue damage. It's, you get banged up. And if you don't play through that, you don't play, right? Uh, Athletes usually have a really good ability to determine whether they're hurt or injured. And that's a
mm,
huge distinction. Um,
mm,
and so I think in today's world, especially in the general practitioner primary care world, they are not used to dealing with the mass of people coming in. that have that ability to just deal with a certain amount of discomfort every day. People want
Mm,
to be completely rid of pain. And I agree with you. You're much better off to have that as a litmus to say, don't bend forward. Um, to say nothing of the fact that, yeah, the meds work great, the anti-inflammatories, they work great in the short term. Steroids are amazing in the short term. They work.
mm,
The cascade and the downstream effects are way worse. The second, third order consequences of those are just not good. Now, I am a huge fan of sending patients out for a Medrol pack, which is an oral steroid you take over 5 days. It really, I tell them, it puts a lot of water on the fire. We need to get this inflammation down. I'm totally for that. What I'm not for is this long standing, chronic, just one, procedure after another. And I am starting to see patients who will say exactly that. Like, hey, I went, they gave me this, they gave me a muscle relaxer, anti-inflammatories, and a painkiller. And I don't want to take any of that because I want to know if I move the wrong way. So inherently, I think people who are really in tune with their body, they kind of get that fire alarm is there for a reason.
mm. Yeah,
Now, if we're
yeah,
if we're decreasing that so that we get better quality sleep, then absolutely that makes sense. But during the
yeah.
day, I want that checks and balances in place.
Most people think that pain is purely structural. They might say, my joint is worn out or my back is weak. But what I see every day is that most pain almost always has an inflammatory component, and inflammation is often driven by everyday foods that quietly irritate the gut and stress the immune system. When you remove those triggers, the body calms down and pain levels follow. That's why I created the pain free plate: 7 foods that naturally help calm inflammation and reduce persistent pain. Get your free guide at bodycheck, that's bodycheck.co.uk/pain free plate. And now let's get back to the show. Yeah, definitely. Yeah, I just want to go back to one thing you were talking about, how, a lot of pain syndromes, injuries, they don't, it's not due to one incident, right? Like, for instance, a car accident, right?
Yeah,
That's one incident.
right.
But what happens to a lot of people that you see and I see as well is what we call cumulative trauma injury, right?
Yeah,
So, my lumbar disc didn't happen while I was in bed that night, right?
right.
It would have degenerated over probably, I'm guessing, probably a couple of decades, right?
Yeah, yeah,
And one of the best examples I can think of. So I don't know if you follow soccer, but in the World Cup in 2002, there was an English player called Michael Owen, and he was like, superstar. And the ball came to him. He was by the sideline, and he just changed direction, not even forcefully, just relatively easily. And his knee just completely collapsed inwards, and his
yeah.
ACL was gone. Right
That's right. Yeah,
now, there's no way that movement would cause a complete rupture of an ACL. It was, I mean, he'd had lots of previous injuries, and especially hamstrings as well. So
yeah.
he hadn't been rehabbed properly before that. But it's just a really good example of how, a very traumatic injury can occur with the slightest bit of pressure because it's had this cumulative trauma over a long period of time.
That's right. And if we had an MRI on him the day before, it probably showed a 75% torn ACL because
Yeah.
these ligaments, they fray over time. Now, you can certainly have a
Mm.
catastrophic. Usually that's going to involve a crazy plant, pivot, twist, and being hit by another player. But when you see these athletes go down in the middle of the field and nobody around them, usually it's because that tendon or that ligament is degenerative to the point where it just took a minor twist to create that tear.
Yeah.
Yeah.
Yeah, absolutely. So when someone wants to get out of pain or even avoid it in the first place, what would be your general approach to helping someone in that situation?
I mean, I think it helps to put it in the context if it's somebody who's coming in with an acute episode, meaning they have pain that's greater than 3 to 4 out of 10. It's an active injury. Now, it may be a chronic recurring thing, but they've experienced a flare up, or it's a new problem. They've never had this pain before. But again, a lot of those are built on underlying chronic things. So I think first and foremost is you have to try to do things to um, mitigate the inflammation in that area right out of the gate. So people always ask, should we use heat or ice? Well, it depends on what the issue is. Um, I think it's important to address fairly early on to try to get in front of some systemic inflammation because it's just pervasive. Most of us today have systemic inflammation, and it may be a real problem. It may be not so real problem, but are they taking things like a good fish oil? If the answer is no, that's an easy fix to try to get on the nutrition train because one
Mm,
of the big drivers in inflammation, we can just talk on them real quick, physical stressors. So that's physical insult to the body is one of the big thing. You stub your toe, you sprain something, you twist something, that's going to cause inflammation immediately around that area. The second one being psychological and emotional stress, right? Increased cortisol levels. And now we're getting into hormone imbalance. The next one is omega 3 to omega 6 imbalance. Our diets heavily favor, this omega 6 imbalance.
mm,
I think most studies today show that it's like a 15-to-1 ratio when back in the day it was like a
wow.
1-to-3 ratio. Yeah,
Mm,
so 15 times as much omega-6 as omega-3, and back in the day, it was like 1-to-3. So, when you think back to our ancestors, how they woulda ate. So, those essential fatty acids are important because they help to produce anti-inflammatory properties in the body, prostaglandins and things like that. And then, managing, cortisol and managing sleep. So, when we're talking about from a nutritional standpoint, that's a fairly simple thing to just add in to get them at least having that conversation. When a patient has other issues, like they have autoimmune disease, fill in the blank. It could be, psoriatic. It could be fill in any of the blank autoimmune
mm,
disease, Crohn's, ulcerative colitis. Um, I think a lot of times it's important to co-manage that with a clinical nutritionist who can really look at what are they putting into their body that's driving inflammation. Um, but in terms of acute sports medicine, we want to try to triage that acute initial pain, and a lot of times we can do that just from the manual treatments alone. Once you put your hands on somebody and you've localized their pain generator, we're already on the path of removing that mechanical, dysfunction around that area. So constricted soft tissues around a nerve, if you can release that, the nerve already is going into repair and recovery. Now, the challenge with nerves is they take a long time to heal.
mm,
So we want to make sure that we're doing things to deflame the body because then it repairs better. And certainly if it's somebody that has, you know, super intense pain and they're not sleeping at night, then we have to look at things like pain management. And that can start with, a steroid to just get them some immediate relief. So it really depends. The situation's got to dictate, and it's got to be dependent on what is the injury that we're working on.
mm. One of the things that I've heard a lot said is there's no such, there is no relationship between posture and pain. What would you
Hmm.
say to someone that has that viewpoint?
So I would argue that may be partly true, and I would argue also that that's complete BS. What I tell patients, and I heard this from Beth Lewis, so I wish I came up with it, but I didn't. She said, yeah, look, posture's it's a big buzzword now. And most patients, right, when they come in, they will say, I know my posture sucks. I know I could have better posture, but they brush it off like, it's not that big a deal. I like what Beth says. She says posture, and I'm paraphrasing, but she said basically posture is really only an issue if you don't have any other options. Right. So meaning if I'm sitting here and I'm in this computer posture, which most of us have, head forward, that's really only a major issue if I don't have the option to come out of that. Well, I would argue you don't have the option to come out of that unless you work at it. If you're doing mobility and you're doing things like, towel traction, we're doing exercises like chin tucks to try to work that mobility side of the house. If you have the ability to come out, the rest of it becomes just Volutional, like day to day, I tell people there are no biohacks for this. You can get an Under Armour shirt that's going to pull your shoulders back. Ultimately, you just have to catch yourself. The brain is lazy. It's going to want to conserve energy. So if you're jamming on the computer, you're going to go to here and you just have to get
Mm,
yourself out of that position. Frequent micro breaks. It's no different than the ophthalmologist telling people, hey, every 15 to 20 minutes, take a 15-second break from the computer, look 15 to 20 feet away, give your eyes a rest. So I would say, yeah, people say sitting's a new smoking. I mean, sitting is not good for the upright human. It's horrible for
mm,
the lower back. If you can stand, great. But I have patients, especially we saw this a lot during the pandemic when, people were just behind a computer 12 hours a day. They're not
mm,
walking around the office all day. And those that had stand-up desks would tell me, yeah, but I'm standing all day and my back hurts. And I'm like, well, because we're made to move. We're made to move, run, sprint, and lay down. We're not made to stand in one place for any given length of
mm,
time. So if you have a stand-up desk that has the option, you can alternate between sitting and standing. So again, I go back to posture isn't really that big a deal until it is a big deal. And so for the patient who doesn't address their posture, and now they have degenerative arthritis that's maybe beyond moderate stage, those are permanent changes in the spine that are very difficult to release and
mm,
to reduce. Somebody that has really severe arthritis in the lower part of the neck and they're this way, structurally, it's very difficult to make those changes to revert that back. We can make some improvements, but it's better to get in front of it before it becomes a permanent change.
mm.
So,
Yeah, I think a good analogy is if you think, I always liken the human body to a car, right?
yep,
If your wheels are poorly aligned, what do you think is going to happen to your tires?
that
They're gonna
30,000
wear out.
mile
They're gonna
tire
wear
is going to maybe get you 15,000 or less,
exactly, right?
Yep.
Or if the axle's slightly off, is there nothing wrong with that, or do you think that might be a bit dangerous, right? And
Yeah.
and also, the faster you drive your car, if it's out of alignment, the more of a problem you've got, right? If you've got poor posture, if all you do is sit at a desk all day and sit on the sofa and watch TV, you might not get an injury. But if you're a tennis player, right, or a swimmer, or a runner, or a triathlete, and you've
Yeah.
got poor posture, now you're putting so much load through tissues that are not designed to handle it in that position. You're putting excessive stress on parts of the body that's not designed to take those loads. So over
That's right.
time, you're going to get that cumulative trauma, which we've discussed, which is going to end up meeting the pain teacher, as Paul Check would say.
Paul Check. What a guy.
I actually asked him the
Amazing.
question. I actually asked him the question a couple of weeks ago on my podcast about the connection between posture and pain, and he said something along the lines of, "That's the most dumb thing I've ever heard." Next question, something along those lines, which was
Yeah, that
quite
sounds
funny.
like him. Um, yeah, I mean, it's true, and, I would say, one of the things I think that's maybe overlooked is we could argue one of the biggest impacts of poor posture is the strain it puts on the nervous system, and that can be strictly just thought of as compression here and in the lower back, not to mention inside the rack, the thorax area, alongside from here to here is your sympathetic chain. And
Mm,
so, that's why I love yoga so much. It's one of the reasons. Patients ask me all the time, like, yoga will force you to touch ranges of motion you're not touching on a regular basis. So it's back to that use it or use it,
mm,
use it or lose it. And so, yeah, I mean, I can't speak for Paul, but having gone through a lot of his training and knowing, I mean, that's just him telling you that's ridiculous. Posture is very important. I think people like to brush it off because look, it's easy to do, it's easy not to do. I mean, the things we need to do to fix posture for the better, they're really not that complex. If
mm,
we take out somebody with really significant scoliosis, rotation in their spine, lateral deviation, but if we're just talking rounded shoulders, forward head, not moving enough, the strategies and the tactics you need to imply to fix that, they're really not high tech at all.
Yeah.
Um,
Yeah.
and I think even just getting somebody to do yoga once a week. Now, I don't think that's sufficient, but what I tell people is once you're a few months down the road of doing yoga once a week, you're pretty familiar with the basic core movements. Start adding those into your mobility routine daily. Sun sals and moving in and out of down dog, some spinal twisting that helps compress the internal organs, squeezing blood flow into them. You could go back and talk posture. Being in a static position, the body doesn't like stasis. And at
Mm,
night when we're sleeping, the body's recovering and it's dumping inflammation and garbage out of the brain down in the lymphatics in the neck, and the body's repairing. But the body's meant to move. And so if you have poor posture, you're locked into this position. That's a huge issue, and it has big implications on our health cumulatively over time. And it goes back
yeah.
to what you talked about earlier. And it's one of the big tenets of the training and active release is the cumulative injury cycle.
Mm,
Tissues getting tight, friction, increased pressure, decreased blood flow, and then the cycle continues. And I think that's one of the things that's hard for people to wrap their head around is the repetitive motion cumulative factor that, um, it's difficult for them to imagine, but I usually will tell them, okay, if I told you to just sit here and just punch the wall, not hard, just like this, and then I'll come back in 2 weeks. And what do you think your hand's going to look like at that point? And they'll kind of go, yeah, I get it. It's death by a thousand paper cuts, really, when you look at a lot of these injuries that we see. And then the other 10% is the acute sports setting or traumatic slip and fall, car accident, catastrophic event. But
mm.
80 to 90% of the things that affect most of us are cumulative recurring over time.
Yeah, I mean the whole check system really, you can say it's about minimizing cumulative trauma by improving posture, biomechanics, movement quality, motor control, strength, power. But then on the
Yeah.
other side of it is to maximize recovery, right? Because if you're traumatizing
Yeah.
tissues, right, which you are when you
Well,
play sport, right? You're traumatizing
yeah.
tissues.
Yeah. Yeah.
You want them to recover as quickly as possible so that when you next play, they've recovered to some degree. So you're not traumatizing traumatized parts of the body, you know?
Yeah. I think, and it's a lot of times we're quick to blame overtraining, but I think more importantly, it's the under recovery.
Mm,
And, um, professional athletes are going to have their whole training schedule planned out over the course of 12 months, and rest is scheduled in there. It's mandatory.
mm,
And for a lot of us, especially, we can be guilty of just pushing it week after week after week. And if you're not forcing yourself to take some downtime, we get into a situation where you're just digging yourself further and further into a hole until now an injury pops up and you're forced to then take some downtime longer than you would have normally done otherwise. So I think that's one of the biggest things. There's two sides of the spectrum. There's the people who aren't active enough, but the other side of the house is the people who are active to the point where they don't ever take any downtime.
yeah.
And sooner or later that catches up with you. You're okay until you're not okay. Um, and it's difficult to get somebody to recognize that on the front side of the power curve. They usually have to live through it once or twice or multiple times until finally they say, I've had it. I don't want to have this I don't want to be sidelined for 3 months plus whatever because I'm just not prioritizing this. And I think everybody has their own kind of tipping point when they get there that that light bulb goes off and says, okay, I just, I'm not 20 anymore. I can't, I can't just brush this stuff off and be ready to go
Mm,
the next day.
yeah.
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 And
Matt,
that's been my
I know.
experience, and that goes back to what we talked about is having had that athletic background and still being an athlete, because I consider myself I'm still training for life.
Mm,
And, patients come in and they'll see stuff on the wall and they're like, "What are you training for?" And I'm like, "Life. I don't do, Ironmans much anymore. I haven't done one in 10 years." Um, but, having been down that road and been injured, you can talk to people from a place of experience and say, "Look, I'm
mm,
I'm guilty of this too. It's
mm.
just as hard for me to take time off as it is for anybody else." So we're kind of preaching to the choir. And I think that's a valuable experience to go off of, is to sit there and not sit up here from an ivory tower, but say, "Yeah, let me tell you about the last time when I didn't listen," um,
Yeah.
and it happened not too long ago, where I just pushed it for too many weeks in a row. Usually about every 6 weeks, I deload, and I was feeling okay and just kept pushing. And it didn't take a proper deload week, and I'm dealing with a little bit of a lower back injury right now. It's been going on for like 3 months. Part of it is I just haven't had the time to be able to get consistent treatment. So
Mm.
knowing what we know and knowing that the solution is just in the consistency of getting in for treatment enough to get in front of it,
Yeah.
um, it's frustrating, right?
Yeah.
Yeah.
Yeah. I've been there. I've been there. Yeah. Well, I think most of us are wounded healers, aren't we?
I think that makes for some, hey, uh, I think it's a trick up our sleeve, so to speak,
Mm,
and I think it's a battlefield multiplier is what it is in the world of treating, because you've been there, you've had it, and I mean, especially when it's an injury that you've had and you've seen it successfully, resolved. That kind of experience is invaluable as a
mm.
provider.
Yeah.
Yeah, wounded
Yeah.
healers. That's great. Yep.
Yeah. Matt, I know you're pushed for time, so I think we need to wrap up. Probably need to get you back on because I think we could talk for hours. But
Yeah, I'd love it.
where can people find you online? And also, can you just give us a quick little bit tidbit about your book as well?
Yeah, sure. So, Dr. Matt Fontaine, most platforms, drmattfontaine.com, at Instagram, Dr. Matt Fontaine, same as YouTube. We have a YouTube channel. It's primarily geared towards the exercise side of the house. Um, and the book, yeah, it launched August. Thanks so much for bringing it up. It's called Only One Body. It's the owner's manual for optimal health and peak performance for life. So, it's a culmination of what I've seen in 25 years of practice, and really what it is it's a basic primer into human physiology, and it clarifies and explains the human architecture, starting off with how humans are built, how we move, why and how we break down. More importantly, what do we do when we do break down? How do I assemble the right healthcare team? Starting with a precision diagnosis and then moving into training, fuel, recovery. We talk about mindset. And then we finish off with a chapter on self preservation and longevity. And I brought together some subject matter experts to introduce the readers to people they can go look for to deeper dives, whether it's Matt Walker for sleep or Peter Attia on longevity. Um, and it's really, it's true north is I wrote it to be a guide to help people be able to be their own self advocate, because their doctors just sadly aren't going to do it for them. And the better
Mm.
educated you are as a patient, the better questions you're going to ask, the better conversations you're going to have with your doctors, and be better poised to find the right providers that are going to listen to you and help you to come up with a proper course of action. So it's available
Yeah, and I
on
know,
Amazon, Audible, Spotify, everywhere books are these days.
you talk about pain and inflammation as well, specifically in the book as well.
Yeah, we talk about it in the chapter. There's a chapter dedicated to it. Again, it's very high level stuff, but I introduce some concepts. We talk a little bit about regenerative medicine. I mean, that could be a book in and of itself. So I just wanted to expose the reader to the world of regenerative medicine and where does that fit in. But I think it's important for people to understand, what is pain and inflammation. They hear these terms, and Very hard to understand what their level of knowledge is, but I think if they understand it a little better, it really starts to just kind of tie everything in together, and they realize just how important it is to get in front of it and deal with, um, especially systemic inflammation, because it is ultimately the main driver behind every chronic disease that we have. It's one of
Mm,
the main three, you
mm.
know.
Yeah, yeah.
So, you
Excellent,
know,
excellent.
um,
I'll make I'll make sure all the links are in the show notes as well.
awesome. Thanks
Max,
so much for
thank you
having
so
me. This is a
much.
blast.
Yeah, it's been really good fun. And I'll say we probably need to get you back on at some point because I'm sure there's lots more we could talk about.
Yeah, really cool to connect with another ART doc. That's really awesome.
Yeah, it's good fun. So that's it from Dr. Matt and me for this week. But be sure to tune in, same time, same place, next week on Beyond the Pain. Thanks for listening to Beyond the Pain. If this episode resonated, please follow the show, leave a review, or share it with someone you know who's been struggling. And remember, pain is not permanent. With the right insight and support, you can turn it into power. Until next time, stay open, stay strong, and keep moving beyond the pain.